Care Lead Nurse at Transforming Cancer Services team for London, and welcome to our Cancer Community of Practice webinar. Just a little bit around the community of practice and some housekeeping. As you mentioned, it will be recorded and recording will be available afterwards. Also, we'll be sharing the slides afterwards by email to everybody that's registered. So a reminder about keeping yourselves on mute unless you're talking, otherwise it's very disruptive for the other people listening, and also it really messes up the recording. So please do try and make sure you're muted. Probably better to keep your cameras off when speakers are on, it just helps with bandwidth and the quality of the connection. We've got a big group today. I think we had 130 people sign up in the end, so it might be quite busy with questions, etc. So probably best to use MS Chat. If there's a question that doesn't lend itself to chat and you want to speak, when we get to that point, if you raise your hands, we'll try to accommodate that. So this is the agenda for today. We're going to be covering cancer risk assessment. We've got two speakers that I'll introduce shortly, but just a few words really about our cancer community of practice. It's a London regional cancer community of practice. It's a collaboration with Central London Community Health Trust, Academy and NHS England's Workforce Training and Education. And it's a pan-London forum, but we open up our webinars to anyone nationally. So welcome to people who have joined from around the country and also to our London colleagues. And what might be nice actually at this point, if you introduce yourselves in the chat, just say where you're from and what your role is, that would be great. And then we'll get a sense of who's on the call. So our community of practice basically brings together healthcare professionals, nurses, AHPs from primary care, community and secondary care with an interest in cancer. So we have a mix of sort of specialist nurses and AHPs and generalists. And our steering group that runs to kind of bring these events together is a mix of people from those settings. And we have a series of face-to-face events and webinars which will be running throughout the year for 24-25. And we'll give you a bit more details at the end if you're interested in coming along to some further sessions. So these are some of the topics that we've covered in 24-25 and some of our previous topics from last year. If you do join our mailing list that I'll mention at the end, you'll get access to our website and you'll be able to look at previous sessions that have been recorded as well. And these are some of the topics that we're sort of developing for 24-25. So, with no further ado, I'm going to hand over to our first speaker, who is Michelle Weston, who's from Guy's and St Thomas's. She's the lead cancer family history nurse specialist. So over to you, Michelle.
Thank you, Sandra. So today will be myself and Natasha. I hope you enjoy our presentation. I'll be doing the first part and then handing over to Natasha for the second part. And then we'll have some time in between for any questions that people may wish to raise. So really today, some of the aims that we'd like for people to understand is the cancer risk assessment service in the context of a family history of breast and bowel cancer, just to understand some of the type of patients that we see in our service and whether it's a family history or whether it's a referral to their local genetic service, to understand the referral pathway from primary, secondary and tertiary care, and that's based on national NICE guidelines, and just to increase awareness of our role when we are providing a family history assessment.
Can I just quickly jump in just to say I'm not sure if your camera's on. And I think you haven't taken control, but I can put the slides forward for you. It's no problem.
Oh, sorry.
That's okay.
Is that better? Sorry.
Can't see you.
Yeah, Michelle's camera is on, but the slides weren't moving.
Okay.
Sorry.
Right. No problem. That's great. Thank you.
There we go.
We can help you move them on, Michelle. If you need some help, just let us know.
Sorry, I didn't do the last bit. I think I've got it now. So So we know over the last 10 years or so, there has been an increase in demand in the public wanting to have a personalised risk assessment. And this really in part has been driven by some well-known people in the public that have shared their family history of breast cancer and their genetic status. And so we have nice guidelines that we follow that give us clear management of how we should look after men and women with a familial history of breast and ovarian cancer. And more latterly, we then expanded our service, and now that includes men and women who have a personal and or family history of bowel cancer. And we know that most people, most individuals, they don't actually require a genetics input, and they can actually be managed in our service by specially trained nurses. And just to give some context to this, last year we saw a total of 459 patients. Sorry, out of those, 459 patients were seen by us, and they didn't require a risk assessment. And similar to bowel, primarily, we saw most of those patients in our service, and they didn't need a referral onto genetics. And I've got some more figures later just to highlight that. So with a cancer risk assessment service, the aim of family history clinics is that we are compliant with the NICE guidelines, giving men and women an individualised risk assessment. As a service, we are embedded in the clinical genetics department. And then there is a family history network throughout the southeast in Kent for breast and bowel. And these primarily are run by breast care nurses or bowel cancer nurses that, as part of their role, they have an extended role and they're given a risk assessment, and they're running sort of aside once a month, maybe a family history clinic. We're unique because we're a service in its entirety. That's what we do for the majority of the time, is that we're running clinics for people that are being referred to us who require a risk assessment. We go through specialist training. So this Guy's and St Thomas's run a course once a year, which goes through breast and bowel genetics. They go through family history. They also go through consenting to store DNA samples. So it's an extensive program for people that are family history or also see patients in their clinics who are affected with breast and bowel cancer. Alongside that, there is a nucleus academy, and on there is a course that can be done online that is similar, that gives sort of a foundation, and I've got the web address for that, which I can share at the end. To become a family history nurse, we go through, as I say, training, assessment and competencies, and these are completed by genetic counsellors. So that is for all nurses that do the family history, whether it's in here or the ones that are running clinics throughout Kent and the surrounding areas. And then as a department, they do an annual family history update day to ensure that we're kept up to date. As I'm sure some of you are aware, that genetic testing is continuing to evolve. So as more testing, such as mainstream, things are evolving. So really, just to give you an idea of how the flow is in our, and the next two slides, how we run the service. So as I say, we're embedded in the genetics clinic. We are overseen by a genetic counsellor, and then there's myself, and then we've got a team of nurses. So apart from Natasha, there's 2 other nurses, and then we're very lucky we have admin support as well. And essentially our service started back in 2010, and it started through a charity grant, because what they wanted to do was to try and ensure that people who wouldn't necessarily access services in hospitals could then access services in the community. So historically, a lot of our clinics were in the community. And our service, we cover the London boroughs of Bromley, Lambeth, Lewisham and Southwark, and we have referrals from healthcare professionals, primary care, nurses, and then also for the breast side of it, we're quite unique, and we take self-referrals. And we work closely with breast screening units who are local to us, so King's and St George's. So this really just gives an idea of the process through one of our clinics. So essentially, patients are referred to us. They're identified in primary care, or it could be in secondary care. So if somebody attends a breast unit because they're worried about a lump and they're asked about family history, so that's another way we have referrals. So then they're referred to us, and then they're triaged depending on their referral, whether they're for us or whether they're for clinical genetics. And essentially, people that are seen in clinical genetics, it's mainly if there is a known gene mutation in the family, patients with specific cancers. So they could have a family history of breast cancer, but there may be some other cancers in the family, so they may be more appropriate to be seen in clinical genetics. Jewish ancestry, we know that there's certain genetic mutations associated with breast cancer genes that are seen more common in the Jewish population. So in a genetics appointment, the patient is seen by a genetic counsellor. 3-generation family tree is collected. If appropriate, genetic testing is offered, and there's a discussion regarding risk reduction and screening options. If they're seen by us, then similar in a sense that we draw a 3-generation family tree, we can then carry out a risk assessment, health promotion, and then we can then refer to breast screening or genetics appropriate, and then we then provide information for relatives. Now, this just gives an idea of the total number of CRAS referrals that we received in 2023. So it was 847. Primarily, these came from primary care. And so when I spoke about the figure earlier, the majority of those patients were seen by us and didn't require a referral onto genetics. And then we have some from other units. So that's in hospital, so breast units, bowel departments. And then the orange just highlights some people that have self-referred to our service because they've possibly seen our leaflet, because we give leaflets out in the breast screening vans, and they're also given out in the clinics. So, so then here, I just wanted to highlight this slide, this pie chart, just to show that the majority of people are referred for screening, and then some we refer because they are too young or too old to start screening. And so people who are too young for screening, they then have the benefit of knowing what screening potentially they can have in the future. We do have men that are seen because they've got a family history of breast cancer, and then we can also give them advice, primarily for female relatives, but then they can have an appointment as well, and then we can go through being chest aware for them as well. And then it's only a small proportion of people that we actually then refer on to clinical genetics. So some of the reasons why we want to assess somebody's family history of cancer is because they can then have an opportunity to have that discussion about their family history to understand what their risk is. They can then have the opportunity to then attend screening. So whether that's mammograms more frequently than the NHS, or whether it is bowel screening, so colonoscopies. And then there's risk reduction options. So in the scope of people with a family history of breast cancer, if they're at increased risk, then they can consider taking chemoprevention. So for women who are premenopausal, there's the option of taking tamoxifen for 5 years, because following a trial, what they found was that women who took tamoxifen for 5 years, there was a 40% risk reduction in breast cancer. As we know that tamoxifen does not come without some side effects and risks. So we explain to women when they attend for their appointment what those risks are. And then for women who are postmenopausal, there's the option of tamoxifen, raloxifene, and anastrozole. And once again, we run through that. So we discuss that with both moderate and high risk individuals. And then also it's important to know when to refer patients to clinical genetics. And these may be if they need a further detailed assessment, or for instance, if there is somebody if there's a family history of breast cancer and all the individuals have sadly died, and they may be eligible for genetic testing. So I just thought what we could do is I could run through a couple of case studies to give you an idea of a typical family that we see in our clinics. So for instance, so Alison, she's 45 years of age. She attends an appointment in primary care, and she's worried about her family history of breast cancer, and she'd like information about the breast cancer gene test. And this is very typical of who we see in our clinic. They want to have genetic testing. So when we ask about her family history of breast cancer, she shares with us that her mother was diagnosed with breast cancer at the age of 58. A maternal aunt was diagnosed with breast cancer at the age of 65. And then on her paternal side, her grandmother was diagnosed with breast cancer at the age of 79. She doesn't have any other risk factors for breast cancer, but she feels with this family history that breast cancer is inevitable. And often when you see things written down, it doesn't give a picture of what that family history is. So she's referred to us for an assessment. And so throughout her appointments, we can, as I say, collect the 3-generation family tree. We will elicit any information if there's any genetic testing that's been carried out in the family. That may have been done through the NHS, or somebody in the family may have had private genetic testing. We then perform a risk assessment, and at the end I've got the Q Genome app information. And that is a really great app. It's full of information, but that can then give you info. That is a step-by-step asking questions, what the family history is, how many relatives, ages of diagnosis, how they're related to the person that's with you, and then that would generate a report. And there's a wealth of information on there. Then we would then carry out a risk assessment, and that picture gives a moderate risk. So we would assess on separate sides. It doesn't accumulate the risk. So based on the ages of the diagnosis in the family, that would give us a moderate risk. So here, this just gives you an idea of how we draw our family trees. So we collect information about her mother and her grandmother, who both had breast cancer. And then we can explain that she's moderate risk. We can then explain that she would be eligible for annual mammograms, and that is between 40 and 49. So that's moderate risk. And then from 50, it's every 3 years until age 71. And then if she was high risk, she would then be eligible for mammograms annually from 40 to 59, and then NHS breast screening until 71. We would find out if she's on the oral contraceptive pill, if she is menopausal, because we also give women information about the oral contraceptive pill. We talk to them about HRT. HRT is not a contraindication for women with a family history of breast cancer. So we would talk to her about menopause symptoms, and then give information about where to get evidence-based materials, so that she can then, if she can then go back to her GP and be informed of then asking questions around taking HRT and what would benefit her. So then on her paternal side of the family, when there is an intervening male relative, we would shift her up one, but having a first degree relative over the age of 40 does not increase her risk. We would also then talk about chemo prevention, and then we would then have a conversation about breast awareness, lifestyle factors, and then we would then give advice for family. So we would then give advice for her sister and then her maternal cousin, because on the maternal side we would then shift up her maternal cousin, so then she would also be moderate risk. When she's asking about genetic testing, she would not be eligible, because when we're looking at genetic testing, some of the things that are taken into account is age of the diagnosis of the person that's affected, the type of breast cancer, so whether it's hormone positive or triple negative, and then age of diagnosis, and then the family history. Genetic testing is always more meaningful in the person that is affected, because what you're trying to establish was their personal and family history of the cancer due to the majority, which is by chance, or is it due to a genetic mutation that then predisposes other female relatives to developing that type, the breast cancer in the family. So what advice we would give to Alison is currently her risk of a genetic mutation is lower than the threshold for testing, and based on the national test criteria, it would only be that if her mother had a triple negative breast cancer that we would advise any genetic testing in the family. So then we would give information in our letter for her mother to check that. If she didn't have that type of breast cancer, this is not a family history that there would be any genetic testing indicated. Okay. So then the next one is bowel cancer family history. So, here on this slide, we have Ben, and his mother was diagnosed with bowel cancer, as well as his father and grandfather, and he wants regular colonoscopies. He feels that he's got a strong family history of bowel cancer because of both of his parents. Once again, with him, we would then explain that the risk doesn't accumulate. On his maternal side, he would be at near population of bowel cancer. On his paternal side, having a first and second degree relative diagnosed with bowel cancer, he would be at moderate risk, and he would be eligible for a one-off colonoscopy when he's 55, and then the NHS bowel screening, where they send out a kit to do a fit test, and that's at the moment I think around 56, but it's gradually coming to start from age 50 every year, 50 to 59, and then from 60 every 2 years till 74. And one thing here, no testing for him. We would ask him if his mother's had any what they call immunohistochemistry, because anyone that is diagnosed with bowel cancer in the latest NICE guidelines are eligible for immunohistochemistry, and that is to look if there is any genetic markers that could suggest that that bowel tumour could be due to a genetic mutation. And then for his father, as his father was diagnosed under the age of 50, we would find out if historically he had that carried out. If not, then it would be his father that would be referred to his local genetic centre to do tumour testing if that tumour tissue is available. And then for Ben, we would also then talk about bowel symptom awareness and lifestyle factors.
I'm just jumping in to give you a 60-second warning.
Thank you. So as we're collecting family history information, we collect names, ages of diagnosis, treatment given, relationships between the people affected, unaffected, as I say, ancestry, and then if there's any genetic testing that's been carried out in the family. So the importance of recognising a need for a family history assessment is so that people, as I explained, can have access to a risk assessment. The important thing is referring people to, if there is a mutation in the family, they should be going to genetics. If there's no mutation in the family, they're unaffected, then they can come to us for a risk assessment. If they're referred to genetics, normally genetic centres give out a to whom it may concern letter, so it's really important to include as much information as possible to ensure that the person is referred to the appropriate clinic. Just some of the feedback that we have. I think the main thing to take away from this, patients find it really informative, and then they can take appropriate action based on their risk, whether that's information about HRT, chemo prevention, lifestyle factors, and also being breast aware. So really the value of family history services benefits the patient. They have an appointment with the appropriate person. They're able to make informed choices about the oral contraceptive pill, HRT and chemo prevention. We then give them access to the appropriate screening and then health information, so breast awareness. We supply all our patients with links or copies of breast awareness booklets, and then a QR code which then explains what their risk assessment is. And then also we can then provide information for family members. And then there's the benefits to the NHS is cost effective. Genetics appointments are really expensive. And also if somebody goes to a breast unit for a family history assessment, they don't need to be seen there. They can be seen by us. We're also adhering to NICE guidance. We use validated tools. So as I say, we use the genome app, and there's information later for that. And then it's, as I say, it's appropriate use of the services. So that's my part finished. So if there's any questions or anything.
I can see one already in the chat, Michelle, which is, will other cancer types be added in time, do you think, to sort of services such as yours, such as pancreatic cancer?
Yes, so we do, primarily we see people with breast, ovarian or bowel, but we do actually see people, if they're from our area, with a pancreatic family history, if they've got a gastric family history as well. So primarily we do, but we do see other people with those types of cancers. Not really any screening for pancreatic cancer. There is a research study being carried out in Liverpool called EuroPac. So quite often if we see people that fulfill the criteria, then we provide the patient information about that study, and they take lots of information, and if appropriate they move people onto the screening part of it, but that's all dealt with by the EuroPac trial. With people, we do see people with a gastric family history. Primarily often we see people that have mixtures of cancers in the family, so they may have lung, gastric, or leukemias. So then we can explain that although cancer is common, most cancers not linked to each other. For people that have a family history of gastric cancer, for instance, if it's a first degree relative, then we can give them information about H. pylori. So, but obviously if we see somebody in clinic that has bowel cancer, gastric cancer, endometrial or ovarian cancer, then we'd be suspicious that could be due to cancer syndrome called Lynch syndrome. So then it may be that that's the appropriate person, whether it's our patient or somebody else in the family. But if they carry out, say, immunohistochemistry, then you then potentially would unlink those cancers and then base their risk on, say, the bowel cancer, but still give them information about, say, H. pylori, for instance. And the same with pancreatic cancer, we would provide them with symptom awareness, but also take into account the other family history, because we know that breast cancer and pancreatic cancer and ovarian cancer can be linked. So when we're looking at family history, we're taking into account the other cancers to see whether they're linked.
Thanks, Michelle. Another very practical question in the chat is, do we refer via ERS, is one of the questions.
Yes. Now, different, so for instance, we're now on Epic. So ours is slightly different. So I think everything comes via email. But I know in the southeast that we have, I think our referral forms, for instance, are on the DX system, but I think different practices have different processes. But I think some places it is ERS.
Thanks. I had a question actually. You mentioned about HRT and breast cancer risk, and in primary care it's a question that comes up a lot when we discuss HRT with patients. Can you signpost us to some good quality information, patient information that we can share with patients when we're talking about it? What would you recommend?
Yeah, absolutely. So there's a women's health concern, and they've got extensive patient information leaflets. And that is part of the British Menopause Society. So I know they're evidence-based. So happy to share those. And, and we also, when we're talking to some women, when we're talking to women who have menopausal symptoms, sometimes we're trying to elicit what symptoms they have to what we can then signpost them to. So I know in the latest NICE guidelines about menopause, they talk about CBT, and sometimes I'm explaining to women that actually sometimes these can help, and so I would signpost them to, say, talking therapies, because that may help as well. So but they have a plethora of information that we signpost our patients to. And often I say to them that actually it really helps for women to sort of look at exactly the type of symptoms they're having to then determine what they need. and really being informed of the different types of HRT. So there is a booklet that I can also share, that if it's appropriate, I give it to some of the women that I see in clinic. So then they can tick box some of the symptoms that they're experiencing and then share that with their primary care.
Thanks, Michelle. Is there any other questions for Michelle before we move on? You can either pop your hands up or pop them in the chat. We've still got a couple of minutes if people have got questions. Sharon, you've got your hand up.
Yeah, just you mentioned the Q Genome app. So I don't know if you can just advise further information on that and how people might be able to use that in practice, or if that's something that you specifically use yourself.
No. So yeah. So the app was developed here in clinical genetics, and it's tied to the so it's tied to the GMSA. So essentially, if you then the app, you would just download it off of Apple or Android, and then you could then add the area that I think you then add the area of your GMSA. So depending on where you are, so there's like Leeds, and then there's Northwest Thames, there's the Southeast and Southwest Thames. So there's different centres, and then you can go on there. But on the Q Genome app, it has like the different guidelines, and then it looks at, so if say you saw somebody in clinic and you weren't sure if they were for genetics or for family history clinic, you can work through the algorithm of that. And so it would ask, does the person in front of you have a personal history of cancer? And if so, age of diagnosis. So you work through the algorithm, and then it will tell you at the end. So anyone can download that, and it is regularly updated because there is a test directory, national test directory, that they follow when to offer genetic testing, and that is updated when relating to that test directory. So it's regularly reviewed.
Thanks a lot, Michelle.
So I've got the I'll put that in the chat so people can. I'll do that now so people can. I've
put the website address into the chat already,
Michelle,
if that's helpful. And I know you can download it on your phone as well. There's a desktop version as well, I believe.
Yes.
You can use either. And I think it's really useful resource, given that it's a national resource. So anyone on the call here from anywhere in the country potentially could download it and use get their local services and information up. So great.
Yeah, and you can always find out what's in your area. If Southeast and Southwest, I know that we have family history clinics, and then there is in Northwest Thames, Central, and there is dotted throughout the country. So it's just good to find out what's local to you, so that when individuals are in your clinics and they want to find out about what their risk is, then where they can then be referred to.
Yeah. So I think just in the interest of time, we probably need to move on at this point and to our next speaker. The slides seem to have disappeared on my view. Is that correct?
Yes.
Do you want to reshare them, Sharon? Brilliant. And we're going to hand over to Natasha once we get to her slide.
Right at the end.
The way through. Right, so handing over to Natasha Dray, who's the Cancer Family History Nurse Specialist at Guy's and St Thomas's as well. So over to you, Natasha.
Hi, sorry, I was just making sure I've got control. Hi, I'm Natasha. I'm one of the Cancer Family History Nurse Specialists at Guy's, and I'm just going to talk very briefly to you today about MEC. So that is, I don't know if it's working for me. Sorry, I'm just having issues with the slides.
They're moving forward now, I think, Natasha. We've gone
Oh,
to
are they?
making
Oh, sorry, it doesn't
content
look like it's
count.
moving for me. Sorry. I don't know if I've gone too far now. It should be on making every contact count. Oh, I'm not too far. Yeah, there we go. Sorry. There we go. Sorry. So yes, so MEC is making every contact count. And it is something that we use in our clinics to encourage people to make informed choices based on their lifestyle factors. So it's meant to just be a brief discussion with the patient, but it aims to maximise opportunities to look at health and well-being factors that can increase the risk of cancer and other long-term diseases. So it's about empowering individuals and encouraging them to believe that everyone has the ability to make changes and improve their lifestyles. But it's not about telling someone what to do, but allowing them that time to talk, and signposting them to specialist interventions or professionals that can provide the required level of intervention for them. And it's probably something that you might be doing every day yourselves, or something that you're doing and maybe don't even realise that is happening. So this is our MEC framework that we use, and it follows ask, assess, assist, and act. And as Michelle said before, it's very useful in our clinics as we discuss lifestyle factors, because we know that the majority of cancers are sporadic due to chance. So we do inform the patients that 90% of bowel, breast, and ovarian cancers are due to chance. And we also discuss other things with them that could also cause cancers, such as age, hormones, environmental factors, but also making it specific to our individual lifestyle factors. So sometimes in clinics, patients might bring this up themselves, but we always aim to discuss it with them and ask if they would like to go into any further detail or if they have any concerns with their own lifestyles. So, for example, I've recently seen a patient who was there to discuss her family history of breast cancer. She did come out as higher risk based on her family history, and she was very keen to discuss the fact that she was quite a heavy smoker and how that would influence her risk of cancer in the future as well. So we were able to discuss ways that she could go about looking into stopping smoking, and I was able to signpost her to the NHS Quit Smoking app. And with her consent, she was happy for me to refer her to the smoking cessation team at Guy's Hospital as well. So that was a very positive experience. So why are we discussing MEC? So we know that many long-term diseases, including cancer, affecting our population are closely linked to known behavioural risk factors such as tobacco, hypertension, alcohol intake, being overweight or obese, or being physically inactive. And if we can have these conversations in clinic, then we can help patients to identify habits that may be increasing their risk of cancer and other diseases, and signpost them accordingly to services for support. And also, again, educating patients that it isn't just genetics that play a part in cancer risk. Only 5 to 10% of breast, bowel, ovarian cancers are due to inherited genetic causes. And also the importance of being proactive with their own health. So it shouldn't actually increase our workload. It should hopefully reduce it in other ways. So having those brief discussions and providing support, referring someone, for example, to their local alcohol cessation could ultimately reduce their risk of cancer in the future, which is costly and time effective to the NHS. So it should be helpful in those respects. So these are some of the useful links that we utilise in our clinics when we're having these conversations. But it would also be beneficial to look into what services and support is actually available to your patients locally. And the MEC website, which I haven't included on there, sorry, is very useful as it outlines different support that's available for patients in different areas of the UK. But something we've actually found quite helpful in our clinics is that we've made a tip sheet. So we can always have that to hand when we're discussing this, and then we can give them the correct signposting. Obviously, there's a lot of clinics and places that patients can access support, and wouldn't remember that off the top of our heads. So that's just something we found really helpful in our clinics. But most importantly, we need to keep having these conversations. And our aim is to have that conversation with every patient that we see in our clinics. Sometimes we don't always get the time for that, or patients aren't ready to have those conversations. So really just letting them know that you are available as well if they want to get back in touch would be really beneficial. That was my very brief chat about MEC.
Thank you, Natasha. We'll open up to questions again, either in the chat or if people want to pop up their hands. There is a question that I think, I'm not sure who it should be for, either Michelle or Natasha, in the chat around smear testing. I don't know whether you've seen it or not. Basically, someone's asking about somebody who'd had a smear test and then had a colposcopy that was normal and asked to repeat their smear in 25. They're asking what happens to the cells that they found. Is there any tests that are needed before the smear to see what was going on? So I'm presuming they're asking whether any sort of genetic testing might have been done. But if that person wants to elaborate a little bit on the question, that's fine. Or whether I've summarised it correctly. And the other part of the question was the person has family cancer in the family, but don't specify what that is. Do either of you want to come back on that?
Yeah, I mean, we know with cervical cancer, that's not normally one that has an inherited predisposition to it. So when we see people in clinic with a family history of cervical cancer, then the main thing we say to them is just making sure they attend their smear tests. I don't know of anything specific in relation to I mean, unless they do certain testing on those cells, but there's no genetic predisposition with cervical cancer in the family, because it's normally what we normally explain, it's normally due to the HPV virus. But obviously, if they've got a family history of say breast or ovarian cancer, then that can be addressed, in a risk assessment clinic. So a family history clinic.
And Juliet, I think you've answered the question. So thank you.
Good.
Yeah. Okay. Is there any other questions from anybody they'd like to ask, or any comments or reflections on what we've been talking about today that anybody would like to share?
Stunned everyone into silence.
I think so. Did you want to summarise the last slide? I don't know if that was yours, Michelle, or Natasha's.
Yeah, so really it's just, as I say, finding out what is local to yourselves, and then just having awareness of the NICE guidelines. I've put them in the next slide, so you've got some information about those. As we've explained, that the majority of cancers are not due to an inherited genetic mutation, and it's just important referring people to the appropriate clinics, really. So whether it's genetics or whether it is for a family history assessment. So
thanks. There's one final question I've just picked up from the chat. was around people not knowing about their genetic history. Perhaps they've been conceived by IVF or from some other reason they don't know about their genetic history. Any kind of advice around those sort of scenarios?
Yeah, so it is difficult because we do have people that don't always know their family history. The difficult thing is we can only assess people based on their family history. So, we have people in clinic and, maybe that, somebody in the family, or it's come through other channels that there may be a family history. So sometimes we can then assess on that little bit of information that we have. But the difficulty is if we don't know anything about somebody's family history, we don't really have anything to go on to be able to assess. And so that is the tricky thing.
Okay, so a limitation in terms of what you can do. Yeah.
Yeah.
Okay.
Yeah.
Thanks. Hope that answers the question, Rosie. Do you want to go through your last slide? So you were going to mention your references, I think. Or...
Yes, so there's some references here, and then there's just one that I wanted to add. And that is this one here. So that is the Medics Academy. So if anyone's interested in learning some more about cancer genomics, you do need to pay for it, and it's different scales, whether it's nurses or whether it's doctors. But that is a good source of doing a course, and you get CPD and such forth for it. So I think there was one other question about prostate cancer. Can I go ahead and answer that? Have I got time?
You've got 60 seconds.
Okay. So yes. So the only time that we do prostate cancer genetic tests, it depends on what it is in the national test criteria. So if a man has a prostate cancer below the age of, I think it's 60, I can't remember exactly, but that might be, but it also in the context of the family history. If we see men that have a family history and they've got a relative, say in their 60s, diagnosed, we can then signpost them to the Royal Marsden because they're doing a study looking at genetic predisposition to prostate cancer. So, and I can add this information in the chat box if people would like.
I think that'd probably be helpful, Michelle. If there's any guidance that you can link to.
Yes.
Brilliant.
Yeah.
Okay.
So I'll add some other things to the chat box.
Thank you. All right. I'm probably going to move this on in the context of the time. So I want to thank our two speakers, Michelle and Natasha, for their time today, and really, really informative and concise presentation on a complex subject. So I think that was incredibly helpful. I'm just going to talk a little bit about our community of practice and the evaluation for this session, if that's okay. So firstly, call to action. So we want to grow our community of practice. If you've enjoyed our webinar today and previous webinars, please tell your colleagues about it and invite them to join us. And they can do that either by dropping me an email, and my email address is here, or there's a link on the next slide that we're going to share. So on the right hand side here, there's a QR code where you can sign up to our mailing list. So if you when you get the slides, you can do that, and there's a link as well. And then really importantly for us, in order to us to kind of develop and improve our webinars, is having some feedback. So invite you to spend the last sort of 60 seconds or so just to complete the evaluation. You can just take a photo now, and the QR code will take you straight through to a Teams, so a form on MS Forms, and it will probably take about 60 seconds for you to complete it. So really, really easy. And it really helps us in terms of making sure that our webinars are as good as they can be, and we improve anything that you kind of suggest that within our gift improve to improve. There's also opportunity to ask for topics, and if you wanted to speak, you could let us know as well if you've got a passion about anything that you're working on that you'd like to share with our community of practice. Also, please drop me an email. So I'm probably going to leave that last slide up and close the meeting here. In terms of the slides, they'll be emailed to you within the next couple of days. The recording will take a little bit longer, but we'll share the link as soon as it's available. We normally just edit it to make it look as good as possible, and take out some of the things which make it less good, as it were. So it takes a little bit of time to do that, but we'll get it to you as soon as we can. I think there was a question about it in the chat. We can't email it to you, but we email a link to it over the next few weeks. So I hope that's okay. Thanks everyone for their time today, and we look forward to seeing you at our next webinar. And if you join our mailing list, you'll be informed of when they are.